Hello, welcome to the Faculty Development on the Fly series, sponsored by the Teaching Academy at the Robert Larner College of Medicine at the University of Vermont.
Hello, my name is Tess Aulet, and I am a surgical resident at the University of Vermont Medical Center. Today's session will focus on the 1-minute preceptor, a quick and accessible framework that will allow your learners to showcase their knowledge and clinical reasoning and also allow you to maximize your teaching efficiency. Let's first consider the challenge faced when teaching in a busy clinical setting before diving into how this framework can serve as a potential solution. Let's consider a third-year medical student on their surgery clerkship rotation who is working with a surgical resident. The resident sends the student down to see a consult with a chief complaint of abdominal pain, distension, and emesis, and instructs the student to gather a history and physical exam. The student then presents their findings to the resident preceptor. The preceptor then gives the student brief feedback and they see the patient together. Afterwards, the resident pulls up a PowerPoint on small bowel obstructions. They go through this briefly, but they get a new consult, so decide to go see the patient together. In this example, the opportunity to explore the learner's knowledge, clinical reasoning, and assessment are a missed opportunity. While the preceptor is making an effort to teach, a PowerPoint lecture will be filled with lots of information that the learner will likely not retain. So how can the 1-minute preceptor model help in this process? The 1-minute preceptor is a 5-step model of clinical teaching which utilizes simple teaching behaviors or microskills. This framework of clinical teaching was developed by Dr. Nahir and Dr. Stevens in the early 90s and is widely used in medical education today. The behaviors or microskills in this framework are meant to focus on the learner's clinical reasoning and decision making. While it is called the 1-minute preceptor, this was designed to take 5 minutes or less, but may vary depending on the difficulty of the case or the level of the learner. The first step is get a commitment. Learners should be prompted to commit to a diagnosis, differential, or workup plan. This commitment helps to create a sense of ownership or responsibility so that the learner is more engaged in the patient's care and plays a collaborative role in the decision making. Probe for supporting evidence. Once the learner has committed, the preceptor must then explore the decision-making process by asking how the learner got to their conclusion. This step helps the preceptor to better understand the gaps in the learner's knowledge. These should attempt to get the learner to think out loud and provide a window for the preceptor to understand how they got to their commitment, and also highlights areas for targeted teaching. Teach general rules. Based on what the learner has revealed in the first 2 steps, the gaps can be identified in data gathering mistakes, clinical reasoning, or knowledge. Once these have been identified, you can target your teaching and avoid overwhelming or underwhelming your learner. By diagnosing the learner in the first 2 steps, your teaching becomes more targeted and more efficient. Instead of a one-size-fits-all approach, you can craft a custom-made experience. Instruction is more memorable when kept to simple general rules or clinical pearls. Reinforce what was done right. In order to ingrain good behaviors and build towards competency, it is important for learners to be told when they perform well by giving feedback. When this is done, it is important to identify behaviors that are specific in order to reinforce this for the learner. If done well, the learner now has all the information needed to continue to use this behavior in future clinical situations. Correct mistakes. Correcting mistakes is very important not only to ensure the learner does not learn bad habits or repeat the same mistakes again, but also for patient safety. With this task, you are identifying specific actions, behaviors, or thought processes that are incorrect, discussing why, and then discussing the potential negative consequences that go along with that mistake. Let's walk through an example of how you would apply this model. As a surgery resident, I send the third-year medical student down to see a consult for abdominal pain, emesis, and distension. The learner sees the consult and gathers the history and physical exam and then presents to me. I start by first getting a commitment. In order to get a commitment, it is important to foster a safe environment and utilize open-ended questions. Don't take over. If you need to gather more data, ask clarifying questions before you ask for the commitment. You can get a commitment by asking questions such as, what do you think is going on with the patient? What studies would you like to order? Avoid shutting them down after a commitment. No, that is the wrong diagnosis. Instead, you should move on to the next step, which is probe for supporting evidence. The cue for this may be after the commitment, the student looks up for confirmation or pauses. It is important to remain neutral and avoid passing judgment at this point, but instead concentrate on collecting evidence on how the learner got to this conclusion. Continue to use open-ended questions such as, what led you to that diagnosis? What facts supported or refuted these? Why did you choose that imaging study?
After asking these questions, it may be apparent that the student has gaps in their knowledge, which then allows you to move on to the next step. Teach general rules. You can now teach in a targeted fashion. For example, the most common cause of obstruction in adults is adhesions. Try to keep it to a few pearls and avoid overloading the learner with a long, exhaustive lecture.
If they truly don't know anything about a small bowel obstruction, after probing for supporting evidence, it may be necessary to advise them a reading topic. Now it is time to give the learner some feedback, and we will start with reinforcing what was done right. When using this skill, you are not just praising the learner, you are identifying discrete, specific things that they did well. For example, it was good that you asked about prior colonoscopy history, since neoplasm would be on your differential. Avoid using vague terms of praise, such as good job. The second part of giving feedback is the last step, correcting mistakes. One way to approach this skill is to ask the learner to critique their own performance. If you don't want to use this approach, it is important to be specific when identifying incorrect actions, plans, or behaviors. For example, while colon cancer is appropriate to have on your differential, asking about past surgical history and inspecting the abdomen provides critical history and visualization of scars that will provide information from diagnosis and also surgical treatment. It is also good to discuss the potential consequences of the mistake. Once the mistake has been identified and discussed, focus should be placed on how to avoid repeating it in the future. Avoid vague, generalized statements. In summary, remember to get a commitment, probe for supporting evidence, teach general rules, reinforce what was done right, and correct mistakes. This is an instinctive model that is easily accessible for a variety of physicians in a diverse range of clinical settings. It emphasizes using both positive and negative feedback, but also provides learner autonomy and promotes collaboration with the preceptor. Thank you so much for listening to this session.